doing it within the context of a patient, so you can understand, okay, this is why anatomy matters. This is why biochemistry and pharmacology and physiology and histology and all these other things, this is why they matter, because it's a patient that we're talking about. It's not just, okay, well, this nerve connects to this nerve, which connects to this muscle, and so forth and so on.
A safe haven for innovators to go off the rails. Welcome back to the Off the Rails podcast, a show about the runaway train that is our healthcare system and the innovators working to derail it. This is your host, Sidney Haytoff. Thanks for joining us today, Dr. Aguila. Let's start off with a quick background.
Sure.
I have a couple questions I usually like to ask. Where do you
Please.
practice? What's your specialty? What's your subspecialty? Favorite food? And do you have any pets?
Okay, great questions, all of them. So right now I live in and work in Papillion, Nebraska, which is one of the suburbs of Omaha, Nebraska. Most people think of it as the Omaha metro area. I am double board certified in plastic and reconstructive surgery, as well as ear, nose, and throat surgery. And I did a fellowship in peripheral nerve surgery. And so these days my practice is about 95% focused on pain and surgical solutions for that. So that's from the subspecialty of peripheral nerve surgery, which itself is a subspecialty of plastic and reconstructive surgery. As far as my favorite foods go, oh, that's a tough one. A lot of people ask me that question, and so it's funny because one of the guys that I work with, he likes the, when we first met, he asked me that very same question. I said, well, really depends on what mood I'm in. And so then he said, okay, well, let me rephrase the question. He said, if you knew that you were going to eat a meal and it was the very last one you were ever going to have, what would it
Classic
be?
question.
Yeah, exactly. And I
The
said, okay,
final
well,
meal.
that narrows the focus quite a bit. So it would be white rice, jasmine rice, preferably, and some Maryland blue crabs. And then maybe, probably a feta and a salad with feta and like a nice raspberry vinaigrette and some poached pears and fresh figs in the salad. And then I don't know, for dessert, I suppose I'd finish up with a good traditional Filipino leche flan. My wife is gonna attempt to make it. She's of German descent, but she knows it's my number one favorite dessert of all time, and I try to avoid getting it anywhere other than Filipino restaurants because I find I'm disappointed by anything other than the Filipino variety. So,
She's in for it.
as yeah, that's right. As for pets, I mean, yeah, we had a dog when I was growing up, but we don't have any pets currently. And we used to have, before we moved here down to the Omaha area, we were living out in rural Nebraska, and much against my will, we ended up getting a few cats, mainly because we lived out in the country, and if you had cats that you kept outside, which we did, then they kept the mice from coming into the house because you have a big problem with field mice out in rural Nebraska, and it was remarkable how well they worked. I'm not much of a cat person, but they served their purpose, and the kids were happy with them, and as long as they never came into the house, I was okay with it. So.
Nice. Did they ever bring you back any trophies?
Oh yes. I mean, it was
Love
not
that.
uncommon to step out onto the back porch in the morning and see 3 or 4 of them sitting right there. Like, yep, they were busy tonight,
Oh
you
wow,
know?
that's wild. Well, yeah,
Yeah.
cats are good for that reason for sure.
Oh yeah, yeah. They're ideally suited to that.
So, as a peripheral nerve surgeon,
Yeah.
I think you told me last time we spoke that there may be a handful, a couple hundred of you guys nationwide, guys,
Right.
gals.
Yes, that's exactly right. So, and when I say that, I'm talking about members of the American Society for Peripheral Nerve. So, I believe our membership is up to about 400 people, of which a little over half are PhD researcher types, and the rest are surgeons like myself. Most of us have a plastic surgery background. Some of us have a orthopedic or neurosurgery background, but the vast majority are plastic surgeons who then subspecialized in peripheral nerve surgery. And I mean, there are other people that do surgery on peripheral nerves, like there are podiatrists who do surgery on some of the nerves in the foot. There are hand surgeons who obviously do peripheral nerve surgery in the hands. But there's, I would guess, no more than 200 of us in the country that are comprehensive peripheral nerve surgeons.
Wow. And so what do you attribute that super subspecialty? Like what led you into that?
Well, that's a great question. So, as far as what led me into it, it was a whole series of happy accidents, really. I mean, you know, um, I remember, I think we talked about this when you and I last chatted. Leading up to medical school, everybody would ask me, "Oh, what are you going to do with your life?" "Oh, I'm going to be a doctor." "Oh, wow, that's really cool." And then I remember our first day of med school orientation, and all of us are standing around, and we're all excited because we're about to start on the beginning of our lives, so to speak. And everybody's asking, "Oh, what are you going to do? What are you going to do?" And of course, they ask me, and my answer is, "Well, I'm going to be a doctor." And of course, everybody looks at me like, "Well, duh. We're all in medical school. We're all going to be doctors. What kind of doctor?" And of course, you know, I, I hadn't really considered that before. And so initially, I knew two things. Number one, I wasn't going to be a surgeon, and number two, I wasn't going to do anything psychiatric. And of course, here I am, a pain focused peripheral nerve surgeon, which means I do surgery on patients who have lots of psychopathology because of their pain. They got all kinds of psychological problems and that result from their pain. So, there's that old saying, if you want to make God laugh, just tell him your plans, right? So, but anyway, I knew I wasn't going to be a surgeon. Little did I know. And so for a while I wanted to be a family physician until I did my OBGYN rotation. And then I was like, this is so awesome, delivering babies and being in the operating room and doing surgery and all this really cool stuff. And I had a really great mentor. He was my faculty advisor, and he was the um Dr. Dick Brown, and he was the director for medical student education in the Department of OBGYN at Boston City Hospital. Amazing, amazing professor. My number one favorite professor from all of medical school. Eventually, though, I realized that I wasn't meant to be an OBGYN. And so I was in the Air Force, and I found out about a great opportunity to be a flight surgeon. And I knew that that was a potential pathway to the astronaut program. And when I was a little kid, I always wanted to be an astronaut. And I said, "Wow, I get to be a doctor and an astronaut." So that's what I did. I volunteered for high performance aircraft flying F-16s, and it was so much fun. I really enjoyed it. It was very exciting work, very rewarding work, a great way to really practice medicine and use my medical skills in a way that I had never considered before. But what I realized really quickly was that there were a whole lot of people I knew who had applied to the astronaut program, and they had a lot more letters after their name than they had in their name. And even they weren't getting the "don't call us, we'll call you" letter. And I was like, I wonder, what does it take to actually become an astronaut? And then didn't take much research to realize that there have been more US Olympic gold medalists than there have been American astronauts, and more presidents of the United States than there have been men on the moon. And I was like, maybe I should choose something a little more achievable. And it was at that point that I realized I missed the operating room. And so, the Air Force was looking for somebody to go into ear, nose, and throat surgery. And I realized that that would be really awesome. And so that's what I did. And while I was, so I ended up doing my ear, nose, and throat surgery residency at Mount Sinai in Manhattan. And after that, I was assigned as the chief of ENT, and then eventually the chief of surgery at Andrews Air Force Base in DC, home of Air Force One. But it was during my last deployment while I was assigned there that I ended up doing a lot of head and neck reconstructive surgery. And I realized, you know what, there's even more that I want to do. And so my wife and I spent a lot of time talking about it, praying about it, and realized that's what we were being called to do. And so again, the Air Force was looking to send somebody for plastic and reconstructive surgery training. And so I raised my hand, and they got my application mixed up with somebody else's, and I got to go to Johns Hopkins. so and uh and so it was a great opportunity. I mean, I got to go to one of the most prestigious institutions in the world to be trained by some of the great thought leaders in plastic surgery. And probably the best sign of that was the fact that while I was there, I met the man who would become my mentor, Dr. Lee Dellen, who's kind of the godfather of peripheral nerve surgery. He's got an MD, he's got a PhD, he's a professor of plastic surgery and a professor of neurosurgery. and he ran his own fellowship in peripheral nerve surgery. And he said, "Listen, I want you to come and do my fellowship." And he kind of twisted my arm because at first I was like, well, I don't know if I really want to do that. And next thing I knew, I was doing his fellowship, and I figured, when I was finally done with the Air Force, maybe that'd be about 5% of my practice. But sure enough, again, a whole series of, like I said, happy accidents. I within 6 months of starting up my new practice, I had expected it to be about maybe 5% peripheral nerve surgery and then the rest split between plastic surgery and ENT. Well, sure enough, by Christmas of that year, I was already 50% of my practice was peripheral nerve surgery for pain. And it's been growing organically since. And these days, almost every single patient I see is somebody with chronic pain that we're doing peripheral nerve surgery for.
Interesting. And so one of the things that fascinated me most about our last conversation was the neurectomy procedure and the
Sure,
concept of cutting out the nerve rather than making room for it. I come
sure,
from the ortho MSK space and specifically spine, and you'd cut out the lamina, cut out the spine, and make room for the nerve to reduce impingement. But you told me about cutting out the nerve, which
sure,
is interesting because in some instances it seems like it could preserve mobility and frankly just be a more direct path towards curative treatment rather
sure.
than the conservative routes that a lot of us are taken down because of the insurance carrier clinical pathways that they
Sure.
approve. And so yeah, something that was super fascinating to me. If you could just like dig into that.
Sure. So, as a peripheral nerve surgeon, I mean, there's a lot of different subspecialties or subspecialties, if you will, within peripheral nerve surgery. I mean, there's some really amazing work that's being done by some of my colleagues in a lot of peripheral nerve micro reconstruction. So, people like Paul Soderna at the University of Michigan, as an example, is working on bionic limbs, like the $6 million man, where you lost your arm and then you put this arm on and it's mechanical and you can't tell that it's mechanical. I mean, it's the goal is what they like to call the Luke Skywalker hand. We're not quite there yet. Right now we have the Anakin Skywalker hand, but the fact that you can even do that, I mean, imagine you put this prosthesis on, and I remember seeing videos of some of the work he's done, where you have a guy who's got long sleeves on a glove on, and you can't tell which hand is the natural hand and which hand is the mechanical hand. And it's because of his pioneering work in peripheral nerve surgery that you're able to use the nerve signals to control that hand. Okay. So that's some of the work that's being done by some of the peripheral nerve surgeons. But if you really think about it, it's a small number of people who would benefit from that. I mean, it's a huge benefit, don't get me wrong, right? But it's a relatively small number of people. There are a lot more people who have pain as a result of nerve problems. And there's a small subset of us who focus on doing peripheral nerve surgery to treat pain. And so, what does that consist of? It really consists of two procedures, depending on what problem the patient has. Now, you mentioned that, in spine surgery, it's all about making more room for the nerve, right? And the reality is that in peripheral nerve surgery, just like in spine surgery, and just like in surgery in the central nervous system, a lot of times that's what we do. A lot of times we make room for the nerve. So the best example of that would be carpal tunnel syndrome, right? That's a peripheral nerve problem. We're talking about a nerve that's outside of the spine, outside of the spinal cord in the brain. And so that by definition is a peripheral nerve. And what do we do in that case? We make room for the nerve so the nerve can start working again, right? Another example of that would be neuralgia paresthetica. So for those who are watching or listening that aren't familiar with that, there's a nerve that comes out of the pelvis on the front of the thigh near the anterior superior iliac spine. It's called the lateral femoral cutaneous nerve, and that nerve can get impinged as it passes either through or underneath the inguinal ligament. Well, if you make more room for that nerve, then all of a sudden the nerve can start working again and those patients do great. We see this commonly in people who we see it a lot in cops because they wear those utility belts, and kind of the Batman kind of scenario, right? They got all this heavy stuff on their belt and then that presses on that nerve and irritates it. So the way to treat that is to just change the mechanics of the nerve, make more room for the nerve. Again, similar to what you're familiar with in spine surgery. So that's one area in which we can have an impact. But the other area, which I think was really fascinating, and it takes a little bit of a leap, but not as big a leap as you might think when you give it a little bit more thought, is this idea of neurectomy, of cutting out a nerve. Now, to be clear, I would not propose to anybody that they cut out the median nerve to treat carpal tunnel syndrome. Okay. Or that you cut out like the L2 spinal nerve in order to treat a radiculopathy. Okay. You take a radiculopathy and you make it a radicunothing, you know, you take away the function of that nerve altogether. Right. But why do I say that? Because those nerves are mixed nerves, meaning that they have a combination of motor function and sensory function, right? And so what we don't want to do is take away motor function. We don't want to take away somebody's ability to move. And so that's something we want to avoid, right? So neurectomy really isn't an option for those patients. The patients for whom it is an option are those who have pain or other sensory disturbances, and the problem is with a sensory nerve, a nerve that's strictly sensory, has no motor function whatsoever. So what's the easiest example for me to give you? Patients with what is sometimes called failed back syndrome. Now, I don't really like that term, but it's one that ends up getting used a lot. One of the reasons I don't like it is because when I say that to spine surgeons, they get real pissed off at me. Like, what do you mean I failed? I'm not saying you failed. That's just the term that everybody else uses. But the reality is, I mean, if you look in the literature, as much as 20% of patients who undergo spine surgery for pain have chronic pain afterwards, right? And as much as surgeons, we don't want to admit that not all of our patients get 100% better. If we look honestly in the mirror, we know that for every single procedure we do, if we've done it enough, some of those patients will not have a successful outcome, right? That's just the reality of it. And so then the question is, it's not, okay, how do I beat myself up, or how do I make sure nobody else beats me up, or whatever? It's really a matter of figuring out, okay, well, what's the next thing that I need to do to help my patient so that my patient can get the relief that he or she is looking for, right? And so that the question as it pertains to the lower back is, okay, well, what could be wrong, right? And so this is how I like to think of pain. The reality is there are only four reasons anybody has pain. Okay. And of course, now you're thinking to yourself, as your listeners are as well, okay, this guy's a nut job. What do you mean? I can think of all kinds of reasons people have pain. But if we think about it really simply, there are really only four reasons. So let me give you an example. Okay. So let's say my index finger. Okay. There are only four reasons I would have pain in my index finger. Okay. Number one, there's a problem with my index finger. Duh, right? Okay. Now you could come up with a list of a whole bunch of things that are problems with the index finger, but the reality is they all fall under one category, an end organ problem, right? Okay, so let's say, for instance, the patient doesn't have a problem with their index finger. Well, where else could you look to see whether or not the patient has a cause for pain in the index finger? Well, the other end of the circuit, so to speak, is the brain, right? So a central nervous system problem can cause pain in the index finger, even though there's nothing wrong with the index finger. So what would be an example? Multiple sclerosis causes pain in all kinds of parts of the body, even though there's nothing wrong with those parts of the body, right? Certain types of brain tumors can cause pain in the index finger, even though there's not a problem with the index finger. Seizure disorders. I mean, the list goes on. There's all kinds of central nervous system problems that can do that, right? Give the patient the false impression that something's wrong with their index finger, even though there's nothing wrong with the index finger itself, right? So those are the two ends of the spectrum. In between there, we have the spine, right? What would be an example of a spine problem that could cause pain in the index finger? A radiculopathy, right? Like let's say in the case of my index finger, let's say a C6 radiculopathy, C5, C6, C7, somewhere in that range could cause pain in the index finger. There's nothing wrong with the index finger, but there's a problem in the spine.
And is that
Now,
when you say pain, could
yeah,
that be tingling pain? Are we
it could,
talking
yeah, it could be
excruciating
tingling, it
pain,
could
or is there a
be
range?
stabbing pain, it could be an electric pain, a burning
Got it.
pain,
Okay.
an aching pain. I mean, people who generally treat these have heard all of those in some variation or some combination, right? But here's the challenge, right? So as physicians, most of us have been taught, well, if it's not one of those three, then there's nothing that can be done about it. We just don't know what it is. But the reality is the people who say that have forgotten that there's something that connects the spine to the index finger. And what is that? Well, we call this the peripheral nervous system. And in this case, well, of course, you're thinking, oh, well, that's all fine and dandy in theory, doc, but Give me an example. Well, the easiest example is carpal tunnel syndrome, right? Carpal tunnel syndrome causes pain in the index finger, even though there's not a problem in the index finger. It's not a spine problem. It's not a central nervous system problem. It's a peripheral nerve problem, right? And so that's an example of a peripheral nerve problem that causes pain in the index finger. Well, guess what? You can have that same kind of problem or something related to it in all kinds of places in the body. And in the low back, the nerve that's almost always implicated, and there was I think it was in the British Journal of Surgery. I don't remember which journal it was, but there was a paper published recently that said up to, I think it was 19% of patients who have low back pain, which is not radicular, which isn't due to a spine problem, have a problem with their superior cluneal nerves. Well, that's one of the nerves that I operate on, and that's a strictly sensory nerve that comes from the lumbar plexus. It comes out. There's usually three of them on each side, at least according to most of the anatomy books. Although in my experience, it varies a lot. But in any case, these nerves pop out right over the iliac crest, and they are almost always the cause for pain in these patients who have, let's say, a clean MRI, or they've had successful spine surgery and they still have pain, right? And so some pain doctors, interventional pain doctors, have rightly identified that these are a cause for pain and have offered patients radiofrequency ablation for this, right?
Mhm.
And guess what? It's successful in a lot of patients, right? But what's the challenge with radiofrequency ablation? What are we doing with radiofrequency ablation? We're cooking the nerve, so to speak, right? For lack of a better description, you use high energy and you cook the nerves so that they stop functioning, right? But anybody that does radiofrequency ablation knows and will tell the patient, the effect from this is temporary. It'll last. Maybe you'll get 5 years relief, maybe 4, something like that, but it's not permanent, right? And then the second time you do it, it's not as effective and the effect doesn't last as long, and so forth and so on, until finally it really doesn't have any effect anymore. And not everybody gets great relief from it. And why is that? Well, because there are a lot of variations in the anatomy, and maybe you got 3 nerves, but that patient might have 5. And if you didn't know they had 5, then how are you supposed to know to go after the other 2? And really, the only way to identify that is surgically. I had one patient of whom I did bilateral superior cluneal nerve surgery. He had a lot of variations in his anatomy. On one side, he had one enormous superior cluneal nerve. And then on the other side, he had 9 smaller ones. That was all in the same patient. You would think that his anatomy would be symmetric, but it wasn't. And so, how did we get him the relief he was looking for? We took what would have been a temporary result with radiofrequency ablation. We made it permanent by cutting out those nerves altogether and then putting them someplace where they won't grow back and cause him further problems. And
Wow.
that's
So you
it. That's
cut them
really
out
all we do.
and you
Yeah, we
put
cut
them
them out.
back.
Yeah. We cut them out and then we bury them into the surrounding muscle so that when they do grow, they don't grow into a place where they're going to cause problems.
Interesting.
Yeah.
And so when you're cutting them out, is it literally, cutting like a piece of string and there's just
Oh
a
yeah.
gap or
That's exactly what we do. I cut out, I don't have to cut out a really big piece. I just have to cut out enough to make sure that those 2 ends don't reconnect.
right. Wow.
It's
That's
really, I
wild.
mean, the reality is what I do as a pain focused peripheral nerve surgeon is actually conceptually really simple, you know, because these patients have one of 2 problems. They either have an extrinsic problem with something squeezing on the nerve, again, like carpal tunnel syndrome. And what do? You just make more room for the nerve, right? Or they have an intrinsic problem like a neuroma inside the nerve, and then you just cut out the neuroma. I mean, most surgeons who have done any surgery near or around nerves are familiar with both of these processes. But taking those principles and applying them to all kinds of parts of the body as opposed to just a few limited parts is really, that's really the difference between what I do and what a lot of other surgeons do. And the big challenge in peripheral nerve surgery, at least when it comes to treating pain, isn't the surgery itself. From a technical standpoint, most of our procedures are pretty straightforward. The hard part is identifying, number one, does the patient have a peripheral nerve problem? And then number 2, which peripheral nerve is it? Because that necessitates a good understanding of the anatomy of the peripheral nervous system. And, I mentioned the superior cluneal nerves, right? Most of your listeners, I would guess, have never heard of those nerves before, even though most of us probably saw them when we were in the anatomy lab in gross anatomy in medical school. I mean, if you look in Netter's anatomy or in Gray's anatomy, you'll find the superior cluneal nerves there. So it's not like it's something that nobody knows anything about. But the reality is, there's a limited amount of time in which the anatomy professors can teach us stuff in medical school. Like my dad's a retired physician, right? And when he did gross anatomy, it was 15 months long. When I did gross anatomy back in 19 Forgotten, it was like 4 months long, you know? And then these days, there are medical schools that don't even teach it anymore, right? So, how do you decide what information to teach people if you have a limited amount of time in which to teach it to them? Well, generally speaking, what do? You say, okay, well, we're going to teach them stuff that they can actually use, right? So if the anatomy professor has to decide, well, do I teach them about the anatomy of the heart or do I teach them about the anatomy of the superior cluneal nerves? Well, they're going to say, well, there's all kinds of stuff you can do with the heart, but nobody knows what to do with the superior cluneal nerve, so we'll just leave that by the wayside, right? But what does that do? That introduces a chicken and egg scenario, because I have patients that ask me this all the time. Doc, how come there aren't more people doing this? How come there aren't more people that know this anatomy? Well, there aren't more people that know this anatomy because they haven't been taught this anatomy in medical school. But why weren't they taught? Because nobody knew that anything could be done. Well, why doesn't anybody know that anything can be done? Because nobody knows about those nerves. Why?
No thought.
Because nothing can be done. So nobody knows anything about them. So nothing can be done, and so forth and so on.
So wow. How do you break the cycle? And I say break the cycle because this touches on a concept that I'm pretty passionate about. The long tail of care
Sure.
is what I
Sure.
call it. And
Yeah.
we've seen the long tail of content take hold and the long tail of information, the long tail of media.
Sure.
I think that the long tail of care is coming, and I intend on doing everything I can to support and accelerate that.
Sure.
I think a big piece of it comes down to content and education, as
Absolutely.
you're saying. How do we break the cycle to ensure that these long tail, super subspecialty, super specific conditions and treatments get the distribution and the exposure that they deserve? And
Sure.
frankly, that patients deserve. Because my whole fascination with this concept comes down to the fact that it seems like oftentimes the wrong treatment is rendered for patients because of a limited set of information and background, and patients just end up with the wrong doctor at the wrong time. And now with modern technology and improved provider and patient matching and content, the idea is, we want to start to facilitate and incentivize doctors and clinicians to go down these deeper rabbit holes, get super, super, super sub specialized, and help people in a way that I think could save a lot of time and pain and money. And then
Sure.
one more thing before you go is, you touched on the concept of patients getting RFAs, radio frequency ablation.
Right.
And that is, a step on in some instances, long pathway that insurance carriers set forth for patients when you present with, the standard issue.
Right.
And, from my perspective and in my background, a lot of people waste thousands and thousands of dollars and months and years even accessing those treatments that don't really touch on the core, the root problem, pun
Right.
intended. And so, yeah, it all kind of comes down to how do we drive the right care at the right time by
Sure.
increasing exposure and education. And I feel like it all comes down to breaking this cycle of, big education and a lot of people have issues with clinical education in general. So just want to get your
Sure.
thoughts on all of that. I know that's a lot.
Sure. No, it's a great question. And it's one that I've wrestled with for a long time. When I was in the Air Force, the Air Force has its equivalent of Six Sigma and lean operations. It's called AFSO 21. And I went through the Air Force, saw fit for me to undergo a lot of training in that regard to try to figure out, okay, how do we make things more efficient? How do we make things more effective? How do we do more with less? That was the catchphrase for a long time. And one of the things I learned was that, okay, you need to do what's called a root cause analysis. And, people, particularly in nursing, are very familiar with the idea of a root cause analysis because nurses do that a lot. Physicians, we do that to some extent, but not not in as formal a way as a lot of nurses do, because that's more a part of their training. But if you do a root cause analysis on this series of questions you've asked, it really boils down to two things in my mind. Number one is interest, right? You have to have physicians and medical students who are interested in this area of medicine, right? But the challenge again is a chicken and egg scenario, right? So let's say they're interested. If they don't know that there are actually solutions that exist, well, then that interest dies on the vine, right? And so then the other question is one of anatomy. Now I'm a surgeon, right? Which means I'm number one, I'm arrogant, and number two, I'm biased, right? That's surgeon by definition. You look up those two words in the dictionary, there I am, right? But I recognize, I mean, I love anatomy, right? That's part of my bias. And I think every physician is better off knowing anatomy. That's also my bias, and that's also part of my arrogance, right? I'm like, okay, look, if you knew your anatomy, then you'd be able to identify more of these problems. But that's the truth. When it comes to these peripheral nerve problems, maybe Joe Schmo internist doesn't know how to do the surgery on the on the superior cluneal nerves to help that patient with his pain. But if he knew the anatomy when the patient comes in, he'd be able to say, "Oh, wait a minute, I know that pattern of pain, and it corresponds to this particular nerve." Now, I may not have the expertise to fix the problem, but if I have the expertise to identify it, then I can pass this person on to somebody who does have the expertise to fix it, right? And so, in an ideal world, if I were emperor, what would I do? I'd make sure that the peripheral nervous system was taught more vigorously and rigorously in medical school. But how do we get to that point? I mean, that's not a change that we can make overnight, right? And so, as much as a bottom up approach would be the most effective long term, I think in order to get there, we have to take a top down approach. And so, what do I mean by that? What I'm hoping to do, and and you and I had discussed this in our previous conversation, what I would love to see is a group of surgeons who realizes, wait a minute, there's a world out there of patients who have pain that I don't have to just shove away because I don't know what to do with them. Because I know many surgeons, myself included, before I understood this, when somebody came in and they had pain that I couldn't explain, I was like, just get out of my office. I don't know what to do with you, right? And it wasn't for lack of compassion. It was just, I didn't have the skill set. I was like, I don't know what to do with that. I mean, it'd be like me as an ear, nose, and throat surgeon, with a patient who comes in and says, "Doc, my knee clicks." I don't know what to do with that. Get out of my office, right? I'm like, I don't know what to do with a clicking knee. I mean, I don't know what to do with a clicking knee now, and I've done 2 residencies and a fellowship, right? But I do know who to send them to, which is the difference between a clicking knee and a peripheral nervous system problem, right? Most people don't know who to send them to because they don't know the solutions exist. So, what would I love to see? I would love to see this conversation lead to that light turning on for a whole bunch of surgeons who say, "Oh, wait a minute. I've always wanted to be able to help those patients, but I always felt powerless to do anything about it. Here's somebody that might be able to train me." And that's really what I would love to be able to do. I think the first phase is to raise awareness amongst patients and amongst surgeons that these problems exist. Okay. And that solutions exist for these problems, that there's a systematic way, that's not voodoo medicine that you can use to figure out, okay, what patient has a peripheral nerve problem, which peripheral nerve is it, and then what do we do about it, right? I, for one, would be ecstatic to train surgeons in these techniques. And I've talked for years with a couple of my colleagues about setting up a multi-center peripheral nerve surgery fellowship. There are a small handful of peripheral nerve surgery fellowships in the United States. Dr. Dellin had one. He just recently retired. There's a small handful of us that are his former fellows who are interested in carrying on that legacy, but we're trying to figure out how. Johns Hopkins has a new peripheral nerve surgery fellowship. There's a peripheral nerve surgery fellowship at the University of Michigan. There's another one at Washington University in St. Louis, and to my knowledge, that might be about it. There might be one at UT Southwestern, but I mean that's a small number of centers, right? And most of those programs are not focused on pain. I'll give you one example, one of the ones we talked about previously, right? So let's talk about post-herpetic neuralgia. Anybody that's seen a patient who has chronic pain after shingles knows there's really not a long list of options to help those patients, right? But what if I told you there are options, there are surgical options to help those patients get permanent relief from their pain? Wouldn't that be worth at least looking into, if that was a population that you wanted to take care of? I mean, think about it. According to the CDC, about 1 million new cases of shingles occur in the United States alone each year, right? And then depending on which study you look at, anywhere from 5 to 20% of those people will end up with post-herpetic neuralgia. So even on the low side, that's 50,000 new cases of post-herpetic neuralgia in the United States each year. I can't take care of all those patients all by myself. Even if every single peripheral nerve surgeon that I know, all 200 of us in the United States, were doing nothing but surgery on post-herpetic neuralgia, we still couldn't take care of all of these people. What we need to do is raise awareness so that more surgeons are interested in doing this, and that they get trained, and then they can take care of these patients. And then as the numbers grow, then the patients will begin to realize, hey, there are options, because then, other people who are interested in referring those patients will also become aware of those options.
And that's exactly what I was just going to ask is, do you think that there's a bit of a staged approach where it's a matter of training the physicians who would be referring to you, whether they be mid-levels, primary care docs, anyone who's treating a patient that is hitting up against a dead end with regards to treatment and the disease that they're treating, and also training surgeons who do want to learn how to actually cure the problem through the surgery that you provide? And what does that look like? Because I'll
Sure,
give you the context is like, we're seeing a lot of shift towards specialty opinions
sure,
that specialists are giving to other doctors who are calling them in to give them a sense of what they should do with regards to a care plan. So a
right,
patient presents, they don't know what to do, rather than turn them away because maybe that will add additional cost to the health plan, or to add additional time to the patient's treatment journey. They're calling up a specialist who can give them potentially a better sense for how to treat the patient in a more efficient manner.
sure.
And so I'm thinking that this kind of has that's like a stepwise function into also then training more doctors to be able to treat these long tail issues.
Yes, absolutely. I agree 100%. So, yeah, a staged approach, I think, is what's required. I think the first stage is to train the surgeons themselves. The next stage, as you mentioned, is to train the referral base, right? But I think where you really start to hit that part of the curve that goes vertical is when we start exposing medical students to these concepts. When they're most malleable, when they're most interested in saying, okay, what do I want to do in the world? What is out there? What are the options? What's available? We don't need to get every single medical student interested in becoming a peripheral nerve surgeon, but we do need to get every single medical student familiar with the concepts so that they can at least say, oh, wait a minute, I remember reading something or hearing something about this when I was in medical school. I'm going to look it up so I can figure out who I need to send this patient to. And, there's one person that comes to mind in particular who I think is on the right track for figuring this out. So there's an anesthesiologist by the name of Dr. George Mychascu. And he has successfully founded and started, I think it was 4 or 6 medical schools in the United States in the last few decades. And he has taken it upon himself to start another one at Benedictine College in Kansas. The focus of this school, however, is much different than what most of us have probably experienced previously. So, when I was a medical student, my first 2 years of medical school, every single class that I was taught by a PhD researcher, right? Who had very little, if any, understanding of clinical medicine. And then we had one little class, Introduction to Clinical Medicine, which met once a week, for 2 years, right? And so you, everything we were learning was only remotely connected to clinical medicine. Well, Dr. Machascu said, you know what? I want to build a medical school where all the classes for the first 2 years of medical school are taught by clinicians, people who are actively practicing medicine, rather than by PhD researchers. That way, every single thing that gets taught is taught within the context of a patient, right? And you come in and you say, so he's invited me to be one of the anatomy professors
Sounds
at
so
this medical
logical.
school.
It's like, why
Yeah,
isn't that being done?
exactly.
Yeah.
If your focus is to create expert clinicians rather than expert researchers, then shouldn't you have expert clinicians being the ones that are doing the training? And so in some ways it's a radical concept, but if you think about it, before medical schools formally existed and before residency programs formally existed, how did medicine work? It was very much like carpentry or plumbing, or these days, becoming an electrician. What do? You start out as an apprentice, and then you become a journeyman, and then eventually become a master, right? Well, that's how it used to work in medicine. I mean, you used to find somebody who was a really skilled physician, and you say, okay, I'm going to spend all kinds of time with that person and learn from that person by watching and asking questions, right? Now, I'm not suggesting that we should go back to a model where each medical student is taught by one physician over the course of their entire career. But what I am suggesting is that I think Dr. Machascu is onto something in that he's taking that idea of an apprenticeship model and saying, okay, let's take a whole bunch of masters and put them together in these group settings so that we can expose these apprentices to concepts in medicine from a clinical standpoint while still developing your basic science expertise, but doing it within the context of a patient so you can understand, okay, this is why anatomy matters. This is why biochemistry and pharmacology and physiology and histology and all these other things, this is why they matter, because it's a patient that we're talking about. It's not just, okay, well, this nerve connects to this nerve, which connects to this muscle, and so forth and so on.
Yeah. Wow. So I did not realize that doctors are trained by PhDs. That's
Yes,
ignorance on my part. That's wild. Because yeah, hearing the concept of doctors teaching doctors makes logical sense. And frankly, that was the impression that I was under. It was going
sure.
down.
Yeah.
Um,
Well, especially when you consider that. So the word doctor originally comes from Latin, right? It comes from the Latin word docere. And so docere means to teach. So what is the first duty of a physician? Our first duty is to teach. And who are we teaching? We're supposed to teach our patients. But how are we supposed to learn to teach our patients if we don't have somebody else teaching us how to do that, right? And I think a lot of us as physicians have forgotten that our first priority is to educate our patients on the problems that they have and how we propose to take care of them. A lot of people see themselves just as widget makers and they're like, okay, I see a problem, I'm going to fix it. But the reality is that you can't do that successfully without buy-in from your patient. And so you got to get them educated so that they can then be engaged and invested in their outcome so that they can get a better outcome.
yeah, and look, that will no doubt impact clinical and financial outcomes. The more
Absolutely.
engaged patients are in their care, the more intentional they are about their lifestyle, et cetera, and the better and the quicker they will be, reaching their goals. And so it's interesting how this concept of clinical education and the didactic nature of a patient to provider relationship, physician to patient, it directly impacts in many instances negatively because of the lack of time that doctors have to spend with patients. It
Right.
impacts the quality of care, it impacts the outcomes, and it impacts the cost. And so, yeah, I mean, I always come back to how the prevalence of this type of treatment and the long tail can be a more efficient and effective way of driving better results in a more cost effective manner. And it's always interesting to hear how a lot of the very, very uh, costly and expensive procedures or conditions, let's say, can be sidestepped and more directly treated with the appropriate procedure or treatments that could save a lot of money and time if treated and used at the right time. So it gets back to this whole concept of right care at the right time. And how do we connect patients with providers, with doctors, with surgeons, with the appropriate level of care so that we're not wasting the expertise or wasting time and money.
Right. Exactly. Well, the whole idea of the right care, right time, I mean, we see this working out well in certain pockets of medicine, but as a general rule, it the system is set up against that, right? And it's due to a series of different factors which have all come into play with each other to give us the system that we have today. But if we talk about, let's take somebody with chronic knee pain as an example, right? If they've got chronic knee pain and you get an X-ray and it's bone on bone, I mean, is physical therapy going to fix that? No. Are a series of injections going to fix that? No.
Is it peer to peer getting you to confirm your diagnosis or the treatment plan going to fix those?
Right,
No.
exactly. Yeah, I'm not an orthopedic surgeon. So, some of your listeners may say, well, wait a minute, he's not an orthopedic surgeon. He's speaking out of turn. So let's talk about something that I am an expert in. So I'll give you a great example. Okay. And this is one of the reasons I left the insurance game. I mean, there's a lot of reasons for that, but this is a great example. Okay. So a patient comes to me and has nasal obstruction, right? They can't breathe through their nose. I look in their nose and they've got a septum that's as crooked as a politician on Capitol Hill. Okay. It's obvious that the anatomy is the problem, right? Did you know that under most circumstances, if I do surgery on that patient without first doing at least a 4 or 8 week trial of nasal steroids, payment for that surgery will be denied because I didn't try the steroids first? I'm like, so the steroids are supposed to straighten out the septum? I mean, it's going to fix the anatomy. Where's the logic in that? Why do I have to have this patient try something which is going to cost more money, delay their care, potentially cause side effects, you know, for no benefit whatsoever other than to check a box for an insurance company? They want to say, oh, the patient needs to try the steroids first. Otherwise, we're going to deny the surgery. I don't know. I've never ever seen a case, nor have I read of a case in the medical literature in which nasal steroids fixed a deviated septum, and yet it's a requirement that we have. Why? Because the insurance companies have put up these barriers in order to protect themselves from surgeons who in the past have been unscrupulous. And I'm not saying all surgeons, it's a small number, all it takes is one bad apple, right? To ruin the whole barrel. And yeah, all it took was a small number of surgeons earlier on who abused the system and then left a bad taste in the mouth of the people who were paying. And so then they had to protect themselves and introduce mechanisms to try to ensure that there was less abuse. Of course, then the physicians felt like they were being abused. So they said, okay, well, we're going to hire people to try to help us get around this. And then it just becomes this arms race between the insurance companies and the people who are providing the care, right? The reality is all that is unnecessary. Okay. Because what we see in my practice, we have a direct specialty care practice. Patients pay us directly, right? And the patient comes to me and I ask them a simple question. What is your problem worth to you? What's worth more, your time, your money, or your problem, right? And I don't know the answer to that question. I don't know how much their problem is worth to them, nor am I going to try to figure that out. It's not, I don't have the right to tell them how much their problem is worth to them. But you know what? The insurance company wants to tell them that. But what I do have the right to tell them and what I have an obligation to tell them is what my time and my expertise are worth. And that's what we do. I say, look, I think you have problem X. And here's what my time and my expertise are worth with respect to trying to fix that for you. If you think that your problem is worth the same, then we can move forward. And if you don't think it's worth the same, well, then, no hard feelings, right? But who gets to make the decision in that case? The patient does, not some person in an ivory tower that's never met the patient before, hasn't examined the patient, doesn't know anything about the patient, but thinks he knows exactly what that patient is worth, and can put a dollar value on that. I can't put a dollar value on your problem, but I can put a dollar value on my time and my expertise. You're the one that decides whether or not that lines up with your problem.
Amen. And it's the patients who deserve that autonomy, that freedom, that control to make that decision.
Exactly. Now, part of my job as a surgeon, as a physician, is to educate that patient so that they understand. We talk about in medicine, particularly in surgery, we talk to patients about the risks, benefits, and alternatives of the surgery we're going to do. But why should we limit ourselves to a discussion of risks, benefits, and alternatives from a surgical standpoint? Doesn't the patient also deserve to know the risks, benefits, and alternatives from a financial standpoint? Isn't it only fair that they know that? I mean, when you go to buy a house, you get an inspection on the house so that okay, is the house going to fall apart or not? But you also have a discussion with your banker or your mortgage lender who's going to say, okay, these are the financial implications of buying this house, right? I mean, when you buy a car, same thing, right? You want somebody to look at the car and make sure that it's in good enough shape, but you also want to know what's it going to cost me and what does that mean for my budget, right? Nobody goes to the grocery store, picks up a gallon of milk, drinks that gallon of milk, and then waits 6 months to find out whether or not the bill that they didn't get when they picked up the milk is going to bankrupt them or not. And yet, for some reason or another, we think that's okay in medicine.
Not for much longer. Look, price
No,
transparency has started to shift that, and I thankfully, that people are actually paying attention these days. But it's wild. Utilization management is the concept that you described, where the insurance carriers try to protect their own financial interests and put patients through conservative treatment pathways just to make sure that they're getting the care that they need. But in many instances, it's black and white. And a lot of that extra cost and pain can be eliminated and avoided. And you
right.
talked earlier about the concept of pain driving mental and behavioral issues, and in the context of financial implications, earnings potential is severely limited, if not jeopardized, by pain. And
Oh,
so,
absolutely.
that kind of consideration, I feel like, is missing from utilization in healthcare in general. And I feel that because of the restrictions and the runaway train, I literally call it a runaway train that the insurance has put us on with regards to the lack of payment and the control, the grip of death that they have over our treatment pathways and the clinical and delivery models that you all were trained to implement on our behalfs. Now we
Right.
have people in, like you said, the ivory tower behind the closed doors dictating treatment when in reality it should be experts. And
Right.
so, yeah, we just got to get back to the
Oh
basics.
yeah. Well, and so the objection that I anticipate that some people are thinking right now is, okay, well, that sounds fine, but healthcare is unaffordable without insurance. That's the usual retort, right? Well, the fact of the matter is healthcare is unaffordable because of insurance, not
Amen.
without insurance. Okay. And I can give you a very concrete example, right? So in the Omaha area, which is where I live, right? In the Omaha area, the average cost of a unilateral one-handed carpal tunnel surgery, which is not to say that the surgeon's operating one-handed. We're talking about just surgery on the one hand, right? Okay. So unilateral carpal tunnel surgery under general anesthesia is about $20,000. Okay. Now, the average family of four in the United States has a deductible of over $7,500. Which means if you're going to do that here in the Omaha area, even if you got even if your insurance will cover everything, beyond that, you still are coughing up $7,500, right? Right off the bat. Now, let's say you have so-called good insurance, right? So let's say your deductible is only $5,000. So that means you're going to pay $5,000 right off the bat for that $20,000 procedure. And then you got to pay another 20% of what's left. So that's your 80-20 co-insurance split, right? So
Hmm.
20% of the remaining 15,000 is another $3,000. Okay, I'll do
Hmm.
the math for you. And so that's a total of $8,000 out of pocket for the privilege of using insurance, right? On top of that, if you do this as a mini open carpal tunnel procedure, it's anywhere from 3 to 6 weeks before that patient is back to work unrestricted, right? Now, compare that to what I can do in my office. Okay, ultrasound guided carpal tunnel surgery. And by the way, I'm going to be presenting this data at the American Association for Hand Surgery meeting later on this week,
Love it.
and it just got accepted for publication in the Journal of Hand Surgery, and there's another paper that we did that just recently got accepted in Plastic and Reconstructive Surgery. So
Oh, congrats.
overlapping data there. So we're excited about that. But having said that, what if I told you I could do carpal tunnel surgery, get results that are as good or better? And what do I mean by that? Instead of waiting 3 to 6 weeks to get back to work, you're back to work in 2 to 3 days unrestricted. Okay. It's all done under local anesthesia, which means you don't have to have somebody to drive you who has to take time off of their work in order for you to get your care. You don't have to take off 3 to 6 weeks of earning potential in order to get your care, right? And I can do both hands under local anesthesia at the same time for less than half of what it would cost you out of pocket to do one hand under general anesthesia and miss all that work. But you don't get to use your insurance.
Oh, hold on.
Okay.
So you do both
Yeah.
for under.
under
8K.
half of what your out-of-pocket cost would be.
Under 4K.
Yes.
Oh wow. I've seen closed carpal tunnels for 5K all in, but that's I guess including the facility. But they really
Yeah.
don't need to be done in the ASC. They could be you have an office-based
I do them in
procedure
my
room.
office
Yeah,
with
look,
ultrasound
and
guidance, because we can
local.
do it under
Yeah.
local anesthesia. Why do I need to add on the extra cost of the facility?
Oh, so you do it all under ultrasound. You don't even do it with an arthroscope.
Correct.
Wow. Okay.
Yeah.
That's very cool.
And I
This
mean,
is a first for me.
yeah, and we, like I said, we're publishing this data. We there have been a few other papers that we've published leading up to this, but we're publishing 1 year outcomes data, and the results are very consistent. These patients get to work much sooner than any other technique, and the long-term outcomes are the same or better than the long-term outcomes with endoscopic or open carpal tunnel surgery. And
Endoscopy,
we're
you're right.
saving
Yeah, it's so
patients a
important.
buttload of money. Why? Because they don't have to deal with their insurance company.
Yeah, nor would anyone want to in that case because, like you said, the rate is going to be way higher than what you would charge them out of
Oh
pocket
yeah,
anyway. Yeah, look, like that speaks to my heartstrings because, especially with carpal tunnel, it's one of the most frequent issues that people contend with that has a massive swing with regards to price. I've
right.
seen carpal tunnels for 10K, I've seen them for 5K, now I hear them for 4K, but yeah, talk
Yeah.
about education. I want to educate people about ultrasound guided carpal
Yeah,
tunnel
for
surgery.
sure. There's about 60 of us in the country that do it,
Damn.
and our practice happens to be one of the centers of excellence for it. That's not my designation. That's the designation from Sonics. They're the company that developed the device that we use for this. And I mean, for me, it's been transformative because, why should we add that extra cost onto the patient if they don't need it? Why should we add the extra inconvenience? Well, part of the reason is that, if you try to do this if you try to do open carpal tunnel surgery in your office under local anesthesia through an insurance model, it ends up costing you more money because you're shutting out all these other patients, right? Um, and part of that is because, when you're dealing with insurance, you have to have an army of billers and coders that you have to pay, which is the part of the reason that you have to drive the cost up in order for it to be affordable. Well, guess what? In my office, I don't have any billers or coders because we don't do anything with insurance. And guess we pass that savings on to the patient.
Amen. Yeah, look, that's why I'm in this space, is that
Yeah.
exact reason, creating that direct connection between doctors, care sponsors, so that we can eliminate the waste and the intermediary bullshit. Yeah,
Oh,
wow,
yeah.
this is I forgot I could curse. This is my fucking podcast. Hell yeah. Um, no, but for real, like I call it off the rails because it's a runaway train. The only
Right.
way to stop a runaway train is to take it off the rails.
Yeah.
I'm fairly passionate about this concept, but it's
I couldn't tell.
also bringing awareness to treatment modalities like that. See,
Sure.
this is something we didn't even talk about the first time.
Yeah.
Ultrasound carpal tunnel.
Oh,
Shit,
yeah.
that's
Yeah.
amazing.
And I do a bunch of other ultrasound guided procedures in my office, but that's the most obvious one. I do lots of ultrasound guided injections, and I do some, diagnostic ultrasound in my office, also musculoskeletal stuff. I mean, for a lot of patients, it's life changing. So one of the things we did talk about is ultrasound guided iovera treatments, right? So cryo for
Mhm,
patients
mhm.
who have pain. Now, you're probably familiar with that because a lot of orthopedic surgeons are using iovera preoperatively to help patients so that they don't end up having to take narcotics after their knee replacement, right? Well, this was taught to me by an orthopedic surgeon. He's the one that taught me how to use the iovera, how to use the ultrasound in order to do that. But when he showed it to me, I mean, the only thing he thought about was knee pain after total knee replacement. I was like, well, wait a minute, dude. You can use this all over the body. He goes, I don't know anything about that. And I was like, I do. I know that anatomy. And, I mean, is that the ideal solution? No, it's not the ideal solution. But what about if I have somebody who comes in who has chronic pain and they got multiple comorbidities? Let's say they've got COPD and they've got coronary artery disease and they're on anticoagulants. They've had 3 strokes, and they're on supplemental oxygen. Am I going to take that person to the operating room? Absolutely not. I am not
Yeah, let
interested
them
in
die on
killing
the
my
table.
patients.
No, yeah,
Exactly.
exactly. No, thanks.
But I do want to help that person, right? And guess what? cryoanalgesia can be very helpful for some patients who have chronic pain as a stopgap, right? So sure, I have to do that every 2 or 3 months, but if I have to repeat it every 2 or 3 months and it prevents them from having to undergo general anesthesia that would otherwise kill them, and it prevents them from having debilitating pain, which keeps them from being able to exercise and lose some of the weight, which is causing some of their problems. Well, why don't I offer them that option, right? Do you know that in most cases insurance won't cover that, right? Because they think, oh well, that's investigational, that's experimental, or
Experimental, not medically
exactly.
necessary. What do they
Exactly.
know?
But we know it works for knee surgery. And I mean, the principle is the same when it comes to other parts of the body. If the
They
patient
just haven't
decides they
caught
want to
up.
do it, exactly.
Yeah,
So
that's
who gets to
wild.
make the decision? Are you going to let the insurance company make the decision, or do you want to make the decision?
Yeah,
I
look,
mean, it's
let's
just like,
take back healthcare.
oh
That's it.
yeah, absolutely. I mean, but we have to get used to the idea that the person that gets to make the decision is the one that writes the check, right? So my very first car was a beat up old Oldsmobile Oldsmobile Omega. Okay, it was a little bit of a rust bucket, and the driver's side mirror was being held on with duct tape. Okay, it wasn't the car that I wanted, but who was writing the check? My dad. And so who got to choose what the car looked like? My dad. And who got to choose what color it was? My dad. And who got to choose what kind of engine it had? My dad. Why? Because he was paying. And you know what? He had a right to do that because he was paying. When I got to buy my first car, did my dad have any say in whether or not I paid for it? Yeah, if I was paying for it myself, did he have any say in what it looked like? No. And I have all the respect for my dad, but that was my call because I was the one that wrote the check.
Let's dig in on this for a second. Your dad was buying you a car, and he
Yeah.
had a budget for the car,
Yes.
right? He didn't necessarily care what color or what it looked like. He had the budget in mind, and that was the car that was available.
Yes.
And so the solution that he generously provided to you was more. It wasn't necessarily, he didn't care so much about the solution itself. He cared about the fact that you needed a car, right? You needed to get from
Yes.
point A to point B. He cared about the condition rather than the solution. He had a
Right.
budget to treat the condition. You stop mooching on him for rides, but
Right.
he didn't necessarily care what kind of car it was. And so I speak about the concept of the condition and paying for the condition versus the solution,
Right.
because that's something that I believe will be a big shift over the course of the next few years. And I intend to help drive this shift is giving people the tools required to be able to make educated decisions and access treatments that treat conditions without bias to the treatment.
Yes.
We need to get away from this obsession over the treatment of itself, the service and which service is being rendered and this and that, the progression in which it's rendered. It all
Right.
comes down to the condition and treating the condition and fixing the problem.
Yes. Yes.
And so
Absolutely.
I think if we give people the tools needed to be able to connect the solution with the problem within a certain guardrails of price, give them the ability to choose which path they want to go down as long as
Yes.
it's proven to treat and fix the problem. We should have the ability to choose. It's our
Yes.
call. You want to give
Absolutely.
me a budget, Dad? You want to give me my allowance? Cool. I get to choose how to spend it.
Yes. Yeah, absolutely. And so what are we talking about here? What we're really talking about is something that's been missing in the finance of medicine, but which still exists to some extent in the medical decision making. And what is that? Transparency, right? So as a physician, as a surgeon, I am obligated to tell my patients what their risks, benefits, and alternatives are, right? They need to have transparency in order to have the ability to make a good decision. So I have to educate that patient, like we talked about before, right? I'm a doctor. I'm supposed to educate, right? And so my job is to educate my patients so they know what they're getting themselves into. We need to expand that, or I should say, recapture that concept as it applies to the finances as well, not just to the medical piece, but to the whole picture. Okay. The patient needs to have that, they need to know cost and outcome in order to judge value, right? Because everybody talks about, you hear people in Congress talking about, you hear all these different policymakers talking about, oh, we need to reduce costs, we need to reduce costs, we need to reduce costs. Well, guess what? What's the easiest way to reduce the cost of a surgery? don't do the
Don't
surgery,
do it. Yeah, exactly.
right?
Reduce the volume. Yeah.
Yeah, exactly. Just reduce the volume and you reduce the cost. If oh well, you need heart surgery. Well, I can't afford, I mean that costs too much. Okay, well then just don't do it. It won't cost you anything
Yeah,
other
then the
than
patient
maybe your
dies.
life. Right,
Yeah,
exactly.
exactly. Yeah, exactly.
You know,
Yeah, but there's the
um
middle ground. Then
there is.
that's what you're getting
There
at.
is. And so what I'm getting at is that patients don't really want to reduce cost. Okay. People don't want to reduce cost. I mean, it doesn't matter how much something costs if you don't need it, right? That left-handed burger flipper, it doesn't matter if you give it to me for free. I'm right-handed. I'm not going to use it, right? I don't care. There's no value, right? So what you want is cost plus plus outcome. And then you take a look at that ratio and you say, okay, what's the value proposition, right? And so let the patient decide, give the patient the information they need so that they have both sides of the equation. So they have the cost and the medical outcome, and then they can judge value for themselves, because that value proposition is going to mean something different to each person, right? Some patients, as an example, they'd be happy if you extracted their infected tooth. Other patients are like, no, 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 I need an implant, right? Well, in dentistry, those patients make those decisions themselves, right? They're like, okay, well, I can get by with just an extracted tooth. I can get by with that gap between my teeth. I don't eat a lot of corn and apples and hard stuff like that. And, my money is better spent elsewhere. Okay. We respect your autonomy and we're going to do that for you. I'm not going to force you to get an implant. I mean, I don't put in implants, but if I were an oral surgeon, I might say that to somebody. I imagine oral surgeons say that all the time. I'm not going to force you to get an implant. I think it's a good idea, but who gets to make that decision? The patient.
Yeah, and that's the interesting component is that I feel like as we improve technology and improve quality and care, I'm seeing more treatment modalities that are available to treat common conditions that people just aren't aware of.
Right.
And it are those modalities who or that we need to drive more exposure to
Yes.
and essentially take matters into our own hands with regards to accessing coverage, right?
Right.
And I think that the shift towards the self-funded employer movement amongst the small, medium-sized businesses who are defecting from the fully insured model because they're seeing that it's as expensive and as much of a scam as the rest of us. Um, that's a massive wedge into what I see as the future of access, the future of coverage, and the future of clinical autonomy, both for patients and doctors.
Right. Right.
And
And this move by Congress recently to make employers fiduciaries on behalf of their
yeah,
employees
we're
when
about
it
to
comes to healthcare
weaponize that
benefits.
fiduciary duty.
Yes, yes. Well, and you know what? They do have that, dude. I mean, from a moral standpoint, let's set aside the legal implications. From a moral standpoint, they have that obligation. My parents didn't, they had a fiduciary responsibility to me when they were buying that car, right? They're like, they weren't gonna, they didn't just say, oh, well, I got $2,000. I'm gonna get you some rust bucket that's gonna blow up when you're driving it down the street. They had to choose something that they knew was going to be safe. That was their first priority. It's got to be safe. We know, it doesn't matter, how affordable it is if it's not safe for you. I mean, I'm their son. They love me. They wanted me to have good things, right? They didn't want me to be laid up in a hospital somewhere, and so I mean, I think that the employers are now in a position where their financial incentives are now aligned with their moral obligations. And as we start to see the impact of that, as you said, the weaponization of that, we're going to start to see employers making decisions which benefit not just the employees, but benefit the company, because a happier employee is a more productive employee.
Yeah, absolutely. Yeah, I think you touched on the concept of alignment, right? It all comes down to aligning the stakeholders in the appropriate way, whether it
Yes,
be the patients and the providers, patients and the care sponsors, i.e., their employers, providers and care sponsors.
right,
And I think the infrastructure, the chassis that we've been stuck with for the last 50 plus years, it will, the cracks are starting to show.
right,
And as this shift towards the self-funded space accelerates, and as more and more patients start to point the finger at their employers who have essentially been sitting back and not really taking an active role in a lot of these benefits administration, I think the jig's up. and it's only a matter of time before, you know, the finger gets pointed at the employers in a way that forces them to change their
Right.
methodologies, and they'll be looking for tools and solutions and doctors and treatment modalities and value. And I think
Yes.
that, you know, those who are ready to deliver that will win in these next, you know, few years. And I'd like to see that happen faster than not. So
Absolutely. Yeah, and I think, I feel really strongly that a lot of our sluggishness has been founded in fear. Okay. So think about this for a second. Okay. I know when I was in the military, this is widely known. I was in the Air Force, and as a group, the people with the second highest IQ were the pilots, the fighter pilots and such. They had the second highest IQ of any job in the Air Force. Who had the highest aggregate IQ, or who had the highest average IQ of any of the jobs in the Air Force? It was the physicians, right? And I'm not saying this to be boastful, right? But we all know that you got to be smart to get into medical school. You got to be smart to be able to survive medical school residency and so forth. I mean, you also have to work hard, right? But as a group, we are some of the smartest people in the country. I cannot believe, I refuse to believe that as a group, we can't come up with better solutions. So then what is the reason we haven't come up with better solutions to date? The reason is fear, because we've been brainwashed over the last 30 or 40 years into believing that there's only one way to do things. And if you don't do it that way, everything's going to fall apart. And how did that come to be? Because of a lack of transparency. That opacity has prevented us as physicians from being able to realize there are other options. And as more and more of us, like myself and Dr. Dan Paul and Dr. George Azude and other people like us, start to step out of the box or just throw away the box, we begin to realize, you know what? A lot of these principles that work in other industries can apply in medicine when we
right.
apply them with the appropriate compassion and the appropriate knowledge and expertise that we have. And patients can get better outcomes, and they can get more affordable outcomes. We see that with the Surgery Center of Oklahoma. We see it with the Texas Free Market Surgery Center. We see it with direct primary care practices like Strata Healthcare. And we see it with direct specialty care practices like mine and like Dr. Dan Paul's and Dr. George Azude's.
Yeah, absolutely. And it's up to innovators and health tech entrepreneurs like myself to help make that easier for you.
Amen.
Um, yeah, I mean, seeing the impact that direct care access has had for the patients that have come through our network, who have come through Gramercy Surgery Center and gotten treatment that they wouldn't have otherwise received, it's life-changing for people. You know, someone called us saviors, and I just wasn't expecting that at all. We've only been in the market for a couple of months, but it's clear the impact that this access has on a group of people who have been marginalized and ignored. And when I say group of people, I mean both physicians and patients.
Yes,
And
absolutely.
so,
And
yeah,
the employers too. I mean, the employers have been they've been, I mean, for lack of a better description, they've been raped by many of these, benefits advisors, so-called advisors, by many of these insurance companies working through a third-party administrator or a broker, and those brokers and TPAs have been responsible for some of the run-up in the cost of healthcare.
the markup. Yeah, that's a
Yeah.
whole other story I could talk about for a long time.
Oh,
But
I'm
yes,
sure.
totally agree. Well, I don't want to keep you too much longer. I know you got
Sure.
dinner to get to. One quick
Yeah,
question
please.
to close out. What does the future of healthcare look like to you in 5 years?
5 years from now. So I think, with the changes in healthcare that we've seen just in the last 12 to 18 months, with the fiduciary responsibility of the employers, we're going to see an acceleration in the move toward direct contracting and direct specialty care and direct primary care. We're going to see more and more employers, and I think this is going to happen rapidly over the next, 12 to 24 months. We're going
Absolutely.
to
If I
see
have
an
anything to do
acceleration.
about it.
Oh yeah. We're going to see more and more employers realize, holy crap, I need to do this. If for no other reason than to keep myself from being sued by my employees, I need to figure out better options. And you know what? Those of us who are providing direct specialty care and direct primary care, we have those options. We are offering those options now. And 5 years from now, we're going to see, if we're not at that tipping point, we're going to be pretty close to it. The point at which, a lot of these healthcare insurers are going to be looking for a different they're going to be looking for something else to do, because they're going to realize, the cow has dried up, that there's no more milk coming from that udder.
Yeah, look, we're going to replace middlemen with middleware and bring about the future that we all deserve, where doctors and patients control the
Yes,
outcomes.
absolutely.
Cool. Well, Doc, give the listeners a way to reach you. I know you have a YouTube channel that I believe post content to. Is that the
Yeah.
case?
Yeah. We've got over 300 videos on our YouTube channel. Most of them are patient testimonials, people who have come to me and we've treated them and they're not too pissed off at me. So yeah, they talk about what they had, the problems they had, and how we were able to help them. And most of our patients find us through those stories. They're like, hey, that was that guy, Matt, that was my story. Or Cindy, that was my story. That was me. I want you to do for me what you did for her. Bring it. So
Yeah.
I would ask you to go to YouTube and look up Total Pain Solutions. Just go to YouTube, look up Total Pain Solutions. You'll find our YouTube channel. You see all those videos right there, and dig in, and then you'll also see information on there on how to reach us.
Very good. And I have every intention of listing your services up on our network transparently for patients to access. And so
Outstanding.
look forward to linking to that in the show notes and sending patients your way.
I really
Dr.
appreciate it.
Demetrio
Aguila.
Aguila. Okay, I'm putting the emphasis on the wrong syllable.
Correct.
Aguila.
Yeah,
Okay,
Aguila.
I'm
You
gonna
got
get
it.
it next time.
All
This
right.
time. Aguila. No, thanks so much. This has been awesome. Yeah, I'm excited for the future, and I really appreciate you taking the time and taking an innovative approach towards practicing medicine in a way that brings more value to people. So thank you.
Thank you.
All right. That wraps up today's episode of Off the Rails. Remember, you can find us on Spotify, Apple Music, YouTube, and other major podcast channels. Don't forget to subscribe to catch all the content. If you like what you hear, please leave us a review and share it with your friends. Your support means a lot and helps us deliver more authentic takes from real change makers. Follow us on Instagram at Go Off the Rails and follow me on Twitter at Sidney Haytoff. Thanks again for listening. Stay genuine and stay true.